We move on to the next talk. Dr. Mini PA will be talking on ophthalmology consultation from neurologist. It is a very elaborative specialty because, as we know, the eye is a window to the brain. We get so many consultations from neurologists. Over to you, Mini.
Good morning. So my topic today is ophthalmology consultations from neurologist. A patient presenting with defective vision, headache, diplopia may be referred to ophthalmologist for detailed evaluation by the neurologist and also for visual field evaluation and disc evaluation. A patient presenting with defective vision may have transient visual loss which lasts for less than 24 hours or persistent visual loss. Transient visual loss can be lasting for few seconds as in papilledema or lasting for few minutes as in retinal and optic nerve ischemia. So always note the onset, progression and duration of defective vision. For example, in central retinal artery occlusion, there is sudden onset defective vision without subsequent progression, whereas in ischemic optic neuropathy, sudden onset with subsequent progression over days. And in inflammatory optic neuropathy, there is subacute onset which progresses over few days to few weeks. And in compressive or toxic or nutritional optic neuropathy, there is insidious onset and gradually progresses over months. And it is important to note the laterality of vision loss and associated clinical features to identify the cause of defective vision. Example, in optic neuritis, there will be painful eye movements, or in demyelinating causes, associated neurological features may be there. And in causes due to orbital or cavernous sinus lesions, there can be associated proptosis or diplopia, or in causes due to giant cell arteritis, patient can have headache, jaw claudication, scalp tenderness, etc. And in defective vision due to retinal and macular causes, patient may complain of metamorphopsia, floaters and photopsia. So coming to clinical examination, it is important to assess visual acuity, color vision, contrast sensitivity, then anterior segment evaluation, in which examination of pupil is very important to rule out relative afferent pupillary defect. Then posterior segment evaluation and visual field evaluation. And depending upon the cognitive status of the patient, we have to decide which are the tests which can be done for each patient. And confrontation visual field testing is a simple and quick test to detect homonymous hemianopia, which is seen associated with cerebrovascular accident. So such patients having CVA will present with, even though they have bilateral homonymous hemianopia, patient may complain of monocular visual loss in the eye with the temporal field defect. And an automated perimetry is important in diagnosis of various optic neuropathies like AION, optic neuritis, and in papilledema, and in localization of the lesion in cerebral causes of defective vision. Then in optic neuropathy, common field defects seen are central and centrocecal scotoma, arcuate scotoma, altitudinal defect, and temporal wedge defects. And in chiasmal and retrochiasmal lesions, the patient will have hemianopias affecting both eyes. In central chiasmal lesion, usually patient will present with bitemporal hemianopia, whereas in retrochiasmal lesion, it is contralateral homonymous hemianopia. As you go more posteriorly, the lesion will produce more identical or congruous types of homonymous field defects. So in lesions in lateral geniculate body can produce a congruous horizontal sectranopia. And lesion in temporal lobe, which affect inferior visual fibers, will produce a homonymous superior quadrant anopia known as pie in the sky defect. And a parietal lobe lesion, which affects superior visual fibers, will produce pie in the floor type of field defect. And in occipital lobe lesion, or usually we get a congruous type of homonymous hemianopia, usually sparing fixation. But in systemic hypoperfusion, where perfusion in both middle cerebral artery and posterior cerebral artery is affected, patient can present with homonymous hemianopic central scotomata. And in bilateral occipital damage, patient can have cortical blindness. A normal pupillary response and a normal optic nerve head appearance will help us in differentiating cerebral blindness from blindness caused by lesions in the anterior visual pathway. The next condition where we get consultation from a neurologist is for evaluation of optic disc to rule out disc edema or optic atrophy. While examining the disc to rule out disc edema, note the blurring of disc margin, hyperemia, filling of cup, presence or absence of spontaneous venous pulsation. And disappearance of already recorded SVP is more significant in diagnosis of papilledema. If there is any doubt, FFA or OCT will help in confirmation of disc edema. And in ruling out optic atrophy, look at the color of the disc, cup, optic disc margins, surrounding retina and retinal vessels, and differentiate primary from secondary optic atrophy. Always rule out consecutive and glaucomatous optic atrophy. Usually in chiasmal lesions, in both eyes, the optic disc will show horizontal botoid atrophy. And in optic tract lesions, the contralateral optic disc may show horizontal botoid atrophy and the ipsilateral disc will show vertical botoid atrophy. Some of the investigations which can be done for these patients include fluorescein angiography, which will help in differentiating true disc edema from pseudo disc edema and also in diagnosis of giant cell arteritis. And fundus autofluorescence will help us in diagnosis of optic disc drusen, which is a cause of pseudo disc edema, and it will also help in ruling out certain maculopathies. And optical coherence tomography will help in various optic neuropathies, as it will give indirect evidence regarding the neuronal loss in optic neuropathy. It is important in compressive chiasmal lesions, as OCT can predict the potential for visual recovery after surgical decompression. Because a patient having significant visual field defect but preserved peripapillary RNFL thickness have excellent prognosis for visual recovery after surgical decompression. Then ERG may help us in differentiating causes due to macular disease and optic nerve disease. Another condition where we get reference from neurologists is a patient presenting with diplopia. Common causes are 3rd, 4th and 6th cranial nerve palsies. And these patients present with diplopia with typical strabismus pattern. We have to do a detailed ocular motility examination and do a diplopia charting. And we can identify the muscles affected and thus the cranial nerves which are affected. When diplopia does not follow a specific cranial nerve pattern, other causes like myasthenia, thyroid eye disease and caroticocavernous fistula should be considered. And always differentiate paretic from restrictive causes of diplopia by forced duction test. And Maddox-Rod test will give us information about the degree and pattern of ocular misalignment. And associated clinical features also help us in anatomical localization. For example, in cranial nerve nuclear and fascicular lesions, there will be associated neurological deficits in addition to ophthalmoparesis. And lesions of cavernous sinus and orbit, patient can present with multiple cranial nerve palsies. And in internuclear lesions which affect the medial longitudinal fasciculus also, patient can present with diplopia. And it is important to note that a non-traumatic pupil involving third nerve palsy always rule out aneurysm at the junction of posterior communicating artery and internal carotid artery. And look for any aberrant regeneration of third nerve. Usually it occurs after traumatic or compressive lesions, not after microvascular ischemia. Then a patient with facial nerve palsy may be referred to ophthalmologist. Always look for the amount of lag ophthalmos, any evidence of whether there is good Bell's phenomenon or not, and any evidence of exposure keratitis. And a patient with headache will be referred to ophthalmologist, and always rule out refractive error, any latent strabismus, any elevated intraocular pressure, or any evidence of ocular inflammation. And don't forget to do a fundus examination to rule out papilledema. Sometimes a patient having hereditary and systemic conditions may be referred to ophthalmologist to look for ocular manifestations of the systemic disease. For example, in phakomatosis like neurofibromatosis, to look for leash nodules. Then to conclude, common indications for referral from neurologist to ophthalmologist include defective vision, where we have to note the onset, duration, progression, laterality and associated features, and diplopia. An ocular motility examination will reveal the cranial nerves which are affected. And in headache, rule out refractive error, strabismus, glaucoma and ocular inflammation. And visual field testing will help us in localization of the lesion. And disc evaluation can be done to rule out optic disc edema and optic atrophy. Thank you.
Thank you, Dr. Mini. So neurology is a very vast topic. Mini has talked in a nutshell. Recently, we had a patient who presented with a partial painful third nerve palsy. And we thought of a patient had a posterior communicating artery aneurysm. And we admitted the patient, and MRI was done, but it turned to be a glioblastoma multiforme, which infiltrating into the brain third nerve, and it is encasing the third nerve. So rare presentations can also occur. So initially we were thinking of this posterior communicating artery, which is the common presentation, as painful third nerve palsy. So sometimes you may get this type of rare presentations also.